Today I will be talking about pulmonary embolism. It's an introduction. Pulmonary embolism is basically a clot that is in the lungs that causes uh, damage and inflammation that leads to circulatory compromise, cardiovascular compromise, and respiratory compromise. And it should be treated within an hour, otherwise it might lead to fatal circumstances. So I will start with signs and symptoms. Signs and symptoms of pulmonary embolism are dyspnea. The person will be short of breath, breathing rapidly, like 40 breaths per minute. 40 breaths per minute. Low SpO2. Their oxygen will be below, let's say, 88. Because they're breathing too fast, they will be blowing out carbon dioxide, so that would be low. Was it below 35? And then pleuritic chest pain. So their lungs, right? Their lungs. That doesn't look like lungs. Okay, this looks more like lungs. So have the pleural around them, and the pain would be there. I think some people have experienced it already. I mean the pleuritic pain. Pleuritic pain starts when they're unable to inhale deeply, and all they can do is take like short breaths, short ones. So they can't take a deep breath. Laughing hurts. Laughing and basically deep breathing hurts. So unilateral chest pain that is aggravated by deep breathing and coughing. The thing is, pleuritic chest pain can be caused by other things also, such as pericarditis, pleural effusion, and pneumonia. And to jump to PE, other factors have to be met before you can consider, is it PE, is it pericarditis, pulmonary effusion, or pneumonia. You have to go through several steps, and there's a little criteria that I'm going to talk about called Wells criteria, which allows you to pinpoint pulmonary embolism. So tachycardia, their heart rate will be above 100. They will become hypotensive. And maybe earlier you have noticed swollen leg, which was the sign of DVT, or pain in the leg. Also hemoptysis, they might be coughing up blood if infarction happens. So coughing up blood. So risk factors for pulmonary embolism would be major surgery, abdominal pelvic, varicose veins, and fractures. With fractures, it could be it could be a fat embolism that travel to the lungs. Sources of pulmonary emboli would be lower extremity or right-sided heart failure, where the clot has formed somewhere in the atrium and it moved. Nope, not here. Right, this one, right atrium, and then moved. Also, PICC lines. PICC lines can get clogged or have on the tip of the PICC line there could be some kind of flap or something can form if it's not flushed often, and then the clot has formed and then somebody flushes it and it breaks off and travels to the lungs. So what are the possible consequences of pulmonary embolism? So it could resolve on its own without any intervention. If a person has a good clotting system breakdown, that plasmin plasminogen that activates the plasmin and breaks down the clot. That can just resolve on its own if it's small. Propagation, the clot will continue to grow. Well, that's mostly talks about in the leg. And then embolism, the clot broke off in the leg and traveled and lodged lungs, heart, brain. Recannulation, which is if it's in the blood vessel. If we have a clot, recannulation, it will start making holes that will allow the blood to go through them. Some kind of adaptation of a clot, I guess. Organization, which is the clot will become part of the blood vessel. It will grow into the blood vessel. Okay. So let's start with small pathophysiology about the clots and why a person would experience certain signs and symptoms. So we have a person who developed a clot. Clot came into the right atrium, went into the right ventricle, and then moved up. It moved up and it lodged itself in the pulmonary pulmonary artery. It lodged itself in the pulmonary artery. And it blocked the blood flow, and so the blood will try to back up. So there's increased pressure here. So pulmonary embolism causes increased intrapulmonary artery pressure. It pushes the blood backwards towards the right ventricle. And there's increased pressure now in the right ventricle. Increased pressure leads to increased work of the right ventricle. Also, it strains it and it dilates. The ventricle dilates and person develops that right side heart failure. You will see the ejacular venous distension, the liver enlargement, swollen legs from the hypovolemia. But I mean, in an hour, it may take less than that to develop. It will take more than that for the symptoms to develop. So, but it will look like right-sided heart failure. Then, right-sided heart failure will lead to the left-sided heart failure, and that's where you will see the hypotension. And because of decreased cardiac output, the neural centers of the brain will stimulate the heart to work harder. So again, we stopped at number 4, increased intraventricular right ventricular pressure, which leads to right side heart dilation of right ventricle, which leads to the heart failure on the left side. So there's decreased stroke volume, less blood is able to be pumped out, so it's a decreased cardiac output, and the blood pressure would go down. Decreased cardiac output, blood pressure goes down. Okay, so all this stuff stimulates the sympathetic response, that flight and fight response, and the person's heart rate will increase, and vasoconstriction will occur in an attempt to bring the blood pressure to normal. The second pathway that happens is within the lung itself. So let's say this is the pulmonary artery or arteries, arterioles, capillaries. So once the emboli lodges in the artery, it goes obstruction, so the blood can't flow this way, so it stagnates. there's something about the carbon dioxide and oxygen, how it exchanges, and it seems like carbon dioxide more easily leaves the blood vessels into the alveoli, while oxygen has to cannot get through because of the inflammation that happens in between the alveoli and the pulmonary capillary. So there's a thing called ventilation and perfusion. Ventilation labeled as V, and then perfusion labeled as Q. So ventilation perfusion mismatch. It has to do something about inhaling some kind of gas to measure it, inhaling some kind of helium or some kind of gas, and then infusion of the dye through the veins, and through some steps they measure ventilation and perfusion. So obstruction happened. There's ventilation perfusion mismatch. White blood cells that are drawn to the area, and they sense the inflammation, sense the problem, they release cytokines. Cytokines travel and affect the bronchioles or bronchioles. They cause them to constrict. They constrict them, and so less oxygen is getting into the alveoli. And as you might remember in anatomy and physiology, they talked about if the blood supply to the area is reduced, then there's certain neural responses where that section will be shut down. So the blood vessels will constrict, and then the bronchioles will constrict, so that, hey, we're not going to use that section of the lung. So all this constriction causes dysfunction of the type 2 pneumocytes, because there's a decreased because this type 2 pneumocytes are malfunctioning. They stop releasing that good old surfactant, that keeps the alveoli open. So once there's no surfactant in the alveoli, they do what? They collapse. And you can see collapsed alveoli on X-ray, which called atelectasis. Good old atelectasis. So you see for example, you see a person, they have chest pain, they're coughing up blood, their O2 is low. What else is there? Their blood pressure is dropping, and they're breathing rapidly, and their heart rate is high. So you don't know if it's a chest pain, and they have chest pain. Do you know if it's the heart attack, myocardial infarction, or is it pulmonary embolism? So you put on an electrocardiogram to check it, and might as well order the X-ray just in case. And they do the scan, and on the scan they show atelectasis in the lung. So you have one clue that it is a pulmonary embolism. So back to our story. So again, obstruction, there's a VQ mismatch, the white blood cells are drawn to the area, cause all kinds of inflammation, they're shutting down the type 2 pneumocytes, and white blood cells also release cytokines. Cytokines travel and cause bronchoconstriction, and that reduces the O2 coming in. So bronchoconstriction will reduce the O2 coming in, and it also will increase it will stimulate the person to breathe more rapidly, rapid breathing, because they are not getting the oxygen, and they will start breathing rapidly, and that will increase the exhalation of carbon dioxide. Once they exhale the carbon dioxide, what it does, it leads to hypocapnia, which is low and low carbon dioxide plays a big role in the acids in our body and formation of the acidic state of the blood, and it will lead to respiratory alkalosis. So another thing, you decide to check what can you see on the ABGs. If you draw the ABGs, you will see that their partial carbon dioxide is low, below 35. And then you will figure out that's respiratory alkalosis. What else? So low O2, as I said, rapid breathing or hyperventilation, it's right here. And also it will lead to more vasoconstriction. So there you go, 2 pathways, why a person experiences certain signs and symptoms and what you can do to check it. By the way, I should have just... okay, whatever. Now, so there's such thing, the predisposition for thrombus formation, some criteria called virtuous triad, and in this virtuous triad we have abnormal blood flow, absence of the blood flow in some places, hypercoagulability, abnormal vessel wall. So if those 3 met, guess what? Pulmonary embolism is pending. So okay, diagnosis. What can we do to diagnose pulmonary embolism? As stated earlier, we can get a chest X-ray, and on chest X-ray we will see the atelectasis. Atelectasis in this area. This is my I represented little emboli, and atelectasis will be here, and because the tissue is dying from lack of oxygen and circular nutrients, there will be a necrosis occurring. So pneumonia and pneumothorax. Pneumonia. What we're ruling out with the X-ray, we're ruling out pneumonia and pneumothorax. So we can see the pleural effusion if the emboli on this side, elevation of the diaphragm, enlarged pulmonary arteries. We'll see large pulmonary arteries on the X-ray. That can clue us into the pulmonary embolism. Wedge-shaped consolidation opacity. Opacity is whitish area. So necrotic tissue due to decreased supply of oxygen. So elevation of the diaphragm and this consolidation or opacity is the sign of pulmonary infarction. There's a few diagram pictures here. So this is one. So we have the gentleman, a patient who has this consolidation here, that white looking area. There it is. And that can clue us to that he is having some pulmonary embolism. Now also we have this consolidation right here. I don't know how close it is to the wedge, but as you can see it's kind of white. That can clue us to that it is a pulmonary embolism. Both pictures are provided by OneNote. Alright. Next, what we're gonna do, we're gonna get the electrocardiogram. So with the chest pain, you would suspect the